important to do it and give you some ideas about how to do it. For those of you who didn't answer, which looks like about 18%, I'm assuming that that's technical difficulties, and I hope that those resolve as we go on. So here we are. We're going to talk about reducing access to lethal means, lethal safety. And let me just give you a quick agenda. First I'm going to do is to really briefly talk about what a public health approach is to suicide prevention and to situate lethal means safety within that public health approach. Talk a little bit about the research data or evidence that help us understand why lethal means safety is important and why it's an evidence-based strategy to prevent suicide. Talk about what it means to store lethal means safety, and then we're going to talk in particular about lethal means safety and what it looks like talking with veterans and service members about it. Shift into talking about implementation at the local level and specific resources and programs that exist from VA and other organizations to think about, once you leave this webinar, how you can implement lethal means safety programming in wherever you work or in your community. Okay, so now we're first going to talk just briefly about a public approach to suicide prevention, what that means, and why it's important. Certainly in news in the past few weeks, I'm sure many of you have heard about recent deaths of important public in our country and heard this phrase, a public health approach to suicide prevention. Certainly it's something that CDC talked a lot about a couple of weeks ago when they updated their data release. A public health approach to suicide prevention means is that suicide is not just a problem for people who are in crisis. It's not just an issue for even people who are in mental health care. But suicide prevention is something that we need to attack at all levels of society and be aware of for all people. And so I have a couple of important statistics here, and then I'll talk more about what I mean by all people. Any of you have likely heard about 20 veterans die by suicide each day. 6 of those were in VA care prior to their death, so the calendar year of or the calendar year prior to their death. And that means 14 of them would not have been in recent VA care. About 1 to 2, depending on exactly how you define service members, die by suicide each day in addition to that. I know that about 123 Americans die by suicide each day. So you can see that veterans make up about 1/5 or 1/6 the number of people who die by suicide each day in this country. Public health approach to suicide prevention means is that in addition to thinking about suicide prevention in crisis services or in mental health services, we have to be thinking about suicide prevention across all sectors of society. So everywhere that veterans and service members move throughout society, we want to think about suicide prevention. So then certainly identifying people who are at risk. It means certainly offering the highest quality evidence-based mental health care. But it also means thinking about how does media talk about suicide and suicide prevention. It means thinking about across social services across the country, where all people work, thinking about faith-based communities, thinking about how veterans and peers interact with each other, really trying to build suicide prevention into all of those sectors to make sure that everyone really understands that truly suicide prevention is everyone's business. They have a role to play and they know what that role is. Think about all of the public and private organizations in our country, pretty much anything you can think of, especially for folks who may be struggling in their lives. Think about how can we raise awareness about suicide prevention? How can we train lay people and non-professional people to recognize and respond to potential suicide risk? of thinking about this public health approach is this National Academies of Medicine classification, which is a way of thinking about how we design suicide prevention interventions. So we have these three columns here on this slide. One for universal interventions. Those are interventions that target everyone in society. So an example of a universal intervention might be a public service announcement. If any of you have ever seen any of these or DOD's public service announcements, that's an example of a universal intervention. An example of a universal intervention that I mentioned before might be reaching out to the media to talk to them about how to talk about suicide safely and prevent contagion. We know how the media reports on suicide can actually impact suicide rates, and we know something, it's a lot to learn, but something about how to report on suicide more safely. Universal intervention is to really reach out to all media outlets and say, hey, listen, how you talk about suicide matters. It impacts everybody. Let's make sure you're talking about it safely. So those are of universal interventions. Selective interventions, the next column over, the one there in light blue, are suicide prevention interventions that groups of people who may be at risk. So to give an example of what I'm talking about, we know that people who live in rural areas are at elevated risk for suicide. Not everyone who lives in a rural area is on an individual level, but as a group, they are at elevated risk for suicide. So selective interventions target these groups or people. Intervention that targets people who live in rural areas would be an example of a selective intervention. Another selective intervention, for example, is an intervention, say, education about storing firearms safely, because we know that people who have access to firearms are at elevated risk for suicide as a group. And so they're an example of a selective intervention and one that's timely for what we're going to talk about today. And the third column are indicated interventions, and these are targeted, these are probably ones you all are quite familiar with, targeted at specific people who we know are at elevated or sometimes very high risk for suicide. So an example of an indicated intervention might be psychotherapy for someone who has a history of a suicide attempt, right? It's an intervention designed for someone who knows is at very elevated risk. And in order to reduce suicide rates nationally, we need many types of all three of these kinds of interventions, again, across all of the sectors that I talked about on the last slide. There are people to sort of say, oh, a public health approach to suicide prevention, this is what they're talking about, that we have interventions at all of these levels, and we're thinking about it across all sectors, just say healthcare. Okay. Example of why public health interventions are syndicated for veterans and why I, as a representative from VA, am here talking with all of you about it is because 50% of the veterans in this country don't touch VA, which means they don't VA health care and don't get VA benefits. So work for the suicide prevention program in VA, and that goal is to prevent suicide among all veterans, but VA only has contact with half of the veterans in this country. So part of public health approach is to think beyond the walls of the VA and beyond the walls of all health care to reach veterans where they are in their communities, again, in all the spaces they move through in their daily lives. So one thing that I think all of us have to begin thinking more about, which is how do we reach veterans and prevent suicide among veterans who don't come into a VA? And this really summarizes what I've said in the past several slides, which is that in thinking about this comprehensive or public health approach, we really need to focus on action beyond the healthcare setting. And to do that, we really need to work with all of you who are on this webinar today to really try to develop an intentional national network of community-based partnerships to ensure that all veterans, no matter where they are and whatever spaces they move through have access to the care and resources they need and have earned. And of course, it follows that communities have slightly different needs, right? The makeup of veterans varies across communities. The needs of those veterans varies across communities. And each locality or city or state or region has its own unique needs and want to think about kind of developing a suicide prevention strategy that meets those needs and focuses on them. And that we in VA are trying to figure out how to help VA and all of its partners do to prevent suicide among veterans and service members. Okay, so now I just want to talk really briefly about the research evidence or data helps us understand why lethal means safety is an important part of suicide prevention. So everybody on this call knows this, but just for me to back up for a second, lethal means safety is this kind of awkward phrase that if you're not in the field, you don't really know what it means, or access to lethal means or reducing access to lethal means. I think to a person who's not familiar with the term, probably even quite clear what it means. What it means is that we know, of course, that in order to die by suicide, you have access to a method that kills you. And one of the things that we have learned, and that I'm going to talk about in subsequent slides, is that if suicidal crises are very brief, and that we can build in time and space between that decision or that impulse to kill oneself and means to do it, we end up saving lives. So an example is if someone decides that they want to die by suicide and gun in their home, if the gun is locked and say their spouse doesn't have access to the key and they don't have access to a means to die, the crisis will pass quickly at a few hours usually, and we will save lives. So that's really the basic premise of this entire intervention for preventing suicide, that by living in time and space between the impulse to act and the ability to hurt oneself will save lives. And all of you know there are many different means or methods people can use to attempt to take their own lives. And we're going to focus on two today, firearms or guns and medications, because those are the two that are quite common in suicide attempts and also lend themselves to thinking about lethal means safety most easily. Other ways to attempt suicide, for example, jumping from a great height or jumping off a bridge is one way. And lethal means safety principles, so again, building in time and space, can also be applied to those methods. I'm not going to talk much about them directly, but I'm happy to during the Q&A if you'd like. So I'm going to start off talking a little bit about veterans and firearms, and then we're going to talk a little bit about poisoning or medications as two particularly lethal means and ways that we can think about building in time and space, again, between the impulse to one of them and actual attempt. Firearms are I think, pretty well-known and well-recognized method of attempting suicide. The general U.S. population, about half of all suicides are completed by firearm. And among veterans, that statistic is higher. About 2/3 of all veteran suicides are completed by firearm. There are many reasons for that, I'm sure. We've laid out a couple of them here. One is, of course, that veterans have a high degree of familiarity with firearms. Some, of course, report that firearms play an important role in their lives, certainly for some of them when they're in the service and even after they separate. We know from some data that veterans in the United States are more likely to own firearms than the general population. So for a poll that was done a couple of years ago, 1 in 2 veterans reported that he owned or had access to at least one firearm. And of that about 50%, 1 in 3 of those people reported that stored the firearm loaded and unlocked. And it turns out that's important because storing your firearm both loaded and unlocked increases risk for suicide and, of course, makes it much easier to use the firearm more quickly. There are a couple of pie charts for what I just talked about in terms of a breakdown of veteran suicide by method. Female veterans there on the left and male veterans on the right. So let's look for a second at the right pie chart, which is the breakdown of suicide methods for male veterans. I'm choosing that one because, of course, most veterans are male still. We know that that percentage ratio is shifting. But again, you can see what I said, 68% or a little more than 2/3 of male veterans who died by suicide in 2014 used a firearm to die. And for female veterans, again, you can see that percentage is less. It's 41%, but it's still quite high, and that's higher than the percentage that uses firearms among female civilians. And you can break down of the other methods there too. So pinning is the official word for overdose. And suffocation, unfortunately, there are multiple ways one can suffocate oneself. A common way that many people know about is hanging. And there are other methods. So what I wanted to talk about was about, as I said, that owning a firearm is a risk factor for suicide. And some people have argued that owning a firearm isn't a risk factor for suicide in and of itself, because maybe firearm owners are just more likely to attempt suicide, or maybe they're more likely to have mental health struggles, right? So that it's that something predisposes people to buy a firearm, and that thing then also predisposes them to attempt or die by suicide. And there are a bunch of folks who have studied this at great length. Data on this slide are from the folks at Means Matter at Harvard University, so Drs. Matt Lurk, Deb Israel, and Kathy Barber. And they did a study where they controlled for a bunch of different factors like I've been talking about. And basically what they wanted to know are people who live in homes with guns, so people who buy guns or have access to guns or have partners who bought guns, are they likely to be at risk for suicide? Are they more likely to have a mental health problem? Are more likely to have thought about suicide in the past? Are they likely to actually have attempted suicide? It is actually no. The reason that having a firearm in the home puts you at increased risk for suicide doesn't have anything to do with you or the person who bought the gun. Simply the presence of the gun in the home that increases the risk. And I think it's important for all of us to think about, and also where appropriate to consider conveying to veterans and service members and their families. But there's nothing in particular about people who like guns or use guns or who own guns that puts them at risk. We know from data that it's just the presence of the gun itself that can increase risk. I'm going to talk a little bit about the other method I mentioned, overdose or poisoning, as it's often reported in a lot of official data reports. So veterans, about 10% of male veteran suicides and about 32% of female veteran suicides are due to intentional poisoning or intentional overdose. One that's been in the news and certainly been a topic of discussion for myself and my colleagues and a lot of folks I talk to is about whether some overdoses or unintentional overdoses may be actual suicides. I think that's a really good question. We for sure don't know an answer in any specific case. When people die by overdose, coroners are reluctant to classify them as suicides unless there is a clear sign that it is a suicide. For example, that the person who had left a note or maybe immediately prior to their death, they called a family member and said they were attempting suicide. In the absence of clear evidence like that, almost all overdoses are classified as non-suicides, as unintentional overdoses. There are a lot of questions, I think, in the veteran and the service member community right now about what we're missing suicides by classifying them as unintentional overdoses. And sort of regardless of what you think of that or how that pans out, I think an important thing to think about is that the people who are at risk for unintentional overdose are the very same people who are at risk for suicide. So people who have substance abuse problems, especially chronic substance abuse problems, that population overlaps quite a bit with the population that's at risk for suicide. And I think that what we're going to talk about here today around lethal means safety isn't just important for people who might say they're thinking about suicide, but anyone who struggles with a substance abuse problem, because we know their risk factors are risk factors for suicide. It's important to think about even if they're not saying they're thinking about suicide. Many of you know one of the most, unfortunately, common ways to die by intentional overdose or by poisoning is opiate medications. It's on the news a lot. About 10 years ago, VA initiated its opioid safety program, and this reports that many veterans were being prescribed opioids chronically. Particular risk are patients who are receiving opiates along with medications that are called benzodiazepines, anti-anxiety medications. And it turns out that people who take those two classes of medications at the same time are at particular risk for suicide and overdose. Other medications that are commonly implicated with suicide deaths are aminophene or aspirin, antipsychotic and some antidepressant medications, and anti-seizure medications. And you are interested in learning more about the breakdown of veteran suicide methods in your state, so by firearm, by poisoning, by other methods. You can go to the state data sheets, which are on the website right here. And I have a little teaser for you, which is we're releasing updated state data sheets in the next couple of weeks. So you'll get updated state data sheets within the next couple of weeks with more recent data than the ones that are listed there. In brief, or in summary here, if we want to think about why does lethal means safety matter, when am I here on a Thursday afternoon taking up your time for suicide prevention? First thing to remember is that access to lethal means increases suicide risk for everyone living in the home. I saw when people were introducing themselves in there were a couple of folks who work in youth suicide. Obviously, the veteran population and the youth population don't overlap all that much. But for veterans who have children or siblings living in the home, access to lethal means, especially firearms in the home, increases suicide risk for everyone living in the home, and especially for children. Another reason that lethal means safety and thinking about it and talking about it with veterans and service members is so important is because the lethality of the method you use to attempt suicide varies across method, and it's important. So, for example, people who attempt suicide by firearm end up dying, or the attempt is lethal, about 85 to 90% of the time. It's very, very lethal. Attempt suicide by medication, so what we commonly again think of as overdose, don't die nearly as often. People are often surprised by this. People who attempt suicide by medication overdose only die between 2 and 4% of the time. A really big difference in lethality. And I think it's something important to keep in mind as we're talking to folks about lethal means safety and suicide prevention, especially about for folks who may be at significant risk or may be approaching a crisis. The last thing that's important to remember is that this, as I mentioned at the beginning, the period of actual suicidal crisis, the period of time in between deciding to attempt suicide and actually making the attempt is often quite brief. In about, from the data that we have, about 3/4 of the time it's less than an hour. We can build in time and space, that example I used initially, for someone who has decided to attempt suicide, has decided to use the gun in his or her home to attempt suicide. We can just build in time and space 30 to 60 minutes in their decision to die by suicide and their ability to access the gun. We will have saved their life. Skip that slide now in the interest of time. And pause now. Discussion.
Thanks so much, Megan. Okay, so I know we got a couple of questions, but I'll encourage our audience to take a minute, and we have a little time set aside right now to have some conversation based on what you're all thinking and where your perspective is. So I think we'll start with the first question. Well, actually, let me just, there have been several questions in the Q&A box about the slides, and we will definitely follow up with all of our participants with copies of the slides. So we'll start with that easy response. The other question that pops up right now is from Oklahoma. And Dr. McCarthy, the question is, what advice for messages or services for the 18 to 34-year-old veterans age group? So, is there a thought of how to tailor some of the outreach to our younger veterans?
A great question. I love the thrust of the question because it assumes that targeted interventions work best, which is absolutely true, right? The same message that works for a 20-year-old female veteran is not necessarily the same message that's going to work for, you know, a 70-year-old Vietnam-era veteran who's living off the grid somewhere. So in terms of lethal means safety in particular, what I think can be important, and we'll talk a little bit about this, is talking to groups or to individual people based on reasons, for example, if we're talking about lethal means safety around guns, that they own their guns. So, for example, people have different reasons for storing a gun unloaded and locked. For some people, it might be safety of the family, say, around their home. Some people, it might be that they struggle with a very personal sense of safety all the time, and that carrying their gun report helps them feel safer. And so when we're thinking about how to approach this conversation with all veterans, and maybe this is more applicable to younger ones in the younger age group, first, really, I think everyone on this call would do this, but really affirm and validate the role, whatever it is, that in this example, guns play in their lives, and really be curious about it with them. And then to try to talk to them from there about, okay, so, you know, these guns because every year you go on a hunting trip with your buddies, so you have these guns, and you have this handgun because, you know, once a month you like to go to the shooting range with your son, right, or whatever the reasons are, to sort of think about that and then talk about it with them based on conversations.
Thank you much, Megan. The other part of that question related to our rural-urban perspective, and I didn't know if there were any other insights that you could suggest as it relates to reach in our rural areas. We hear that question a lot from our teams, and how to support our veterans there, as opposed to outreach in urban areas. And I don't know if that's been a focus that the VA. I know the VA has a focus on rural issues, but I just wasn't sure if there was some specific messaging that had targeted one population versus another, rural versus urban.
Another great question. One I won't pretend the VA hasn't struggled with too, right? Especially how do we reach rural veterans who don't come to the VA for care or don't have benefits? And I think it's an ongoing process for all people who are interested in preventing suicide among veterans and service members and their families, thinking about how we can, provide resources like, for example, telehealth, so that they can get health care home or in their community to them. One thing we do know in terms of lethal means safety about rural veterans is that people who, not just veterans, but people who live in rural areas are often more likely to own one or more firearms and are at higher risk for suicide in general. Again, depending on the community where one lives, another thing comes to mind. I'm less of an expert in the data about this. I'm thinking about overdose risk in rural areas in some parts of the country. I think it's really important, critically important, to make sure that veterans and service members who live in rural areas have some access to health care as a way of preventing suicide.
Very much, Megan. Another question that is coming up in the chat is related to having that conversation about firearms, especially when someone feels, especially a veteran or a service member feels that maybe they'll lose access to their guns permanently. And so you may be going into this a little bit further along, but that's an important conversation when we think about trying to be culturally competent when we're talking to our service members and veterans, getting them to engage with us on this issue. So to hear a little bit more on lessons learned on that front as well.
Thank you, Michelle, and to the couple of people who I'm seeing in the Q&A box wrote in about this in kind of different permutations. This is an important topic. I wish we could spend hours and hours, thinking about and practicing together, all of us, think about how we approach these conversations, which not always, but are sometimes sensitive for veterans. We're going to talk a little bit about it later in the slides. I want to say right now, I'm looking at one of the questions that talks about among some gun owners in California, certainly a fear among some veterans that if I go to mental health care, I might lose my firearm. So we have some empirical validation of this idea in the recent National Academies of Medicine report that was released earlier this year, and focused on VA mental health care for OEF, OIF, and OND veterans. And National Academies of Medicine specifically listed this year an obstacle to seeking mental health care for OIF, OEF, and OND veterans. So it's that we have certainly taken note of. I mean, we've taken note of it before this, and now we're really taking note of it in a serious way, and think about how we might do something to lower that barrier. And I think the scope of this webinar is too limited to think about all of the different state laws and which determine who has a right to own a gun and who doesn't. I'll just say, sort of as a general caveat, we in the VA really try to say very clearly, coming to mental health care doesn't mean you are going to lose your firearms. Clinical providers can't take away firearms. There are some laws, again, they vary by state, that determine circumstances under which someone could lose a firearm. So, for example, in the state of California where I live, if someone psychiatrically hospitalized involuntarily, so against their will, there is a law that says they will lose their firearms for, I think it's 5 years. And those kind of laws that we in VA are thinking about how we can educate providers and veterans about, and at the same time, really encouraging people to come to mental health care. That it's not that if you go to a VA and seek an assessment for what you think, I don't know, might be symptoms of PTSD, that means someone will or even can, because they can't, take your gun away from you. So, but I think an important area to think about, and we in VA are beginning to develop a plan to try to educate providers about this on a state-by-state basis.
Thanks, Dr. McCarthy. Another question, and before we jump back into the content, there's been a couple of questions, especially that relates to the 14 veterans who are not accessing care from the VA, and a couple of our questions have centered around how do we help our veterans consider accessing care at the VA. And so before we move into the next session, I thought I'd pose that to you to see if you had some thoughts that you wanted to share on that front.
I do. I have several thoughts. One is that if a loved one is already having a conversation with a veteran about how they're doing and whether they might need some extra support or resources, I think that is great already. VA offers a national service called Coaching into Care. I think if you Google it, it comes up immediately. I think the website might be coachingintocare.com, but I'm not, .va.gov, but I'm not quite sure about that. But if you Google it, you'll find it. This is a resource that is available to all family members and friends of veterans in the country to help them think about how to talk to a veteran about entering care or getting the help that he or she needs.
Very much, Megan. Okay, so we're going to go now. We have another poll. Actually, we have 2 poll questions at this point.
Ooh.
That yes, I know we're getting wild here. So we will. And actually, no, I was wrong. I'm sorry. We have one. We're on poll question 2. We have 1 poll question now, and then we'll have 2 poll questions later in the session. So it's not getting too exciting yet. But okay, so. This is our poll question, and Phil's going to launch it. True or false, 50% of those who survive a suicide attempt do not go on to die by suicide.
Oh, I think this poll question is from the slides that I skipped. So I'm not sure it's a fair poll question, unfortunately. I'm so sorry. No.
Picking away.
People knew the answer anyway.
Sure. We have about 10 left in the poll, so if anybody else wants to weigh in. And then we'll post it. Okay. All right. All right. The portal is processing everybody's responses, so that should be up in just a second. Patient. There we go.
All right. I did not have skipped these slides. I'm sorry that I skipped them. It was like a pop quiz before you even got the book ready for it. So it turns out that about 90% of people who attempt suicide and survive the attempt don't go on to die by suicide. You can see from this poll that's a surprisingly high number for a lot of people. I think us, especially those who might work in mental health or mental health care, and see people who attempt suicide repeatedly, have a little bit of the idea that, you know, someone really wants to die, are going to find a way to do it. One of them, a myth we talk about in VA gatekeeper training around suicide prevention. And this is that the data really don't bear that out. That if someone's, we know this from decades and decades across many, many studies of research, that if someone attempts suicide or wants to attempt suicide and they survive that attempt or that crisis, 90% of them don't go on to die by suicide. And the reason that's important here in thinking about lethal safety or reducing access to lethal means is that if someone has a suicidal crisis, again, and they really have the impulse to harm themselves and are looking for the means to do so, if we can build in that time and space so that they survive that crisis or make an unlethal attempt and survive the attempt, in 80% of their cases, we have saved their life from suicide for good. So it's a statistic that's important to think about in terms of lethal means safety and in terms of what it means to survive a suicide attempt. That people who attempt and survive, almost all of them or almost none of them go on to die by suicide.
Thanks, Dr. McCarthy, and part of the reason we wanted to highlight that as a poll question is because that's such a startling statistic and such an important part of our conversation today. So thanks. And now I'll turn it back over to you for your presentation.
Thank you, Michelle. And that's what I get for skipping slides. I see now, especially important ones. Okay. So I'll talk a little bit about this issue of, in particular, around sensitivity and talking to veterans about guns or about, again, voluntarily and temporarily reducing their access to firearms. So I want to again emphasize what I started talking about a couple of minutes ago, which is that as a healthcare provider or as someone in the community, unless you're a law enforcement official, and I think then only under certain circumstances, we don't take firearms away from anyone. We can't tell anyone to do with their firearms. And so this is, and I don't think we'd want to. And so this is really a conversation about how to talk with veterans and service members and their families in a way that's helpful and effective, collaborative, and thinking about how to ask in a way that's received well on the other end. I know from talking with a lot of different providers, mostly in VA, but certainly not exclusively, that many clinicians and doctors and therapists and social workers and case managers and so forth are nervous of asking veterans about their guns. And so a number of researchers around the country have sort of said, well, there's a reason to be nervous. How about we ask some veterans and their families what they think about this? And so a group of researchers from the University of Michigan and a couple of other folks conducted focus group interviews with veterans who are mental health patients, with their families, with clinicians, and then with peer specialists, so people who work at the VA but are also veterans and have mental health struggles. And they essentially asked them, does it make sense for VA clinicians or VA staff ask veterans and their families about their access to guns, about how they store guns? And this is a really kind of top-level summary, so it doesn't, of course, include all of the details of all those focus groups. There are two take-home messages here. One of them is that most veterans agreed that psychologists or doctors or case managers or social workers have a role to play in addressing gun access with veterans who are at risk for suicide. So most veterans said, yeah, if my buddy comes to you or I come to you and I've really been struggling and that I'm at risk for suicide, absolutely, you have a role to play, or there's a place and a time in which you can ask me about my access to guns. And most of these participants also suggest very strongly, I think it's an important message for us in VA for sure, that family and friends should be involved in those discussions. So that if I, as a VA psychologist, am concerned about a veteran in front of me, he's been feeling suicidal and depressed, has access to a loaded and unlocked gun, and has been thinking about suicide. Most people, especially veterans, in these studies said an important thing to do would be to involve a family member or someone that the veteran trusted in this conversation about safe gun storage. We also asked a group of VA clinicians across a few different VA medical centers across the country, so some in California and some were in Pennsylvania, about what they thought, these are mental health clinicians, about what they thought about the importance of asking about access to firearms. We asked them in 4 different circumstances. So the first circumstance was the patient or your client comes in and has been suicidal, endorsed suicidal ideation in the past month, doesn't currently. We said it's important to ask about access to firearms if the veteran is endorsing suicidal ideation today, but then he or she has a plan. Ask them, is it important to ask about access to firearms if they're in your office is saying, I'm suicidal today and have a plan to die, but it does involve my gun? And then we ask them, if a veteran comes in and says, if a veteran says, I'm feeling suicidal today and have a plan to kill myself with a gun, is it important to ask the veteran, do you have access to a gun? And you see the response percentages here. So these are data from about 3 years ago. I kind of hope these numbers have gone up. But you see, on the one hand, it's mostly encouraging that most of the mental health clinicians that we polled said 93% of them said if a patient or a client comes in and says, I'm thinking about suicide today, I have a plan to take my own life with a gun, most of the clinicians said it would be important to initiate a conversation about access to firearms in that circumstance, 93%, an overwhelming majority. I wish that were at 100%, but I'm really encouraged by that number. But I'm concerned by the numbers on the left, where only majority, but still only 63% of the clinicians here said they would ask a veteran about access to firearms if the veteran had endorsed suicidal ideation in the past month but was denying it now. The reason that's of concern to me is because of what we know about the nature of suicidal ideation, which is that, and suicidal crises, which is that they can come and go pretty, not only quickly, but unpredictably. So you may not be feeling suicidal when you're meeting with them, but if they go home and something bad happens or a series of bad things happen, like let's say they go home and then maybe their girlfriend breaks up with them, and then they become really upset that their girlfriend broke up with them. They go out and they drink a lot and they get a DUI, and the DUI causes them to lose their job. All of that stuff can happen in a relatively short period of time. It's enough to make people feel quite suicidal. And I think that it's important that we be thinking about counseling on access to lethal means for that group too, the group that may not be feeling suicidal in office, but have been suicidal in the recent past and could be suicidal again. You can hear that clinicians on the whole think it's important in general to ask about access to firearms, and then there's just some variation here in the circumstances in which they think it is. This is a way that asked veterans who thought it was appropriate for a healthcare provider to ask about access to firearms. So it was a national survey. It was a representative sample of veterans. Actually asked the veterans, is it okay, or at least sometimes appropriate, for a healthcare provider to ask you about access to firearms? You can see here that across all 3 of these different groups here, the group of firearm owners who are veterans, a group of non-firearm owners who are veterans but live in a household with a firearm, and a group of veterans who live in a non-firearm household, you can see that all these veterans above 50% or above thought it was at least sometimes appropriate to talk with a healthcare provider about access to firearms. But you can see something interesting here too, that veterans who own guns are less likely to think it's appropriate than those who don't own guns or live in a household without any guns. Finally, I just want to comment on what actually firearm advocacy organizations think about providers or social service providers talking with veterans about access to firearms. This is where one of the areas of sensitivity or perceived sensitivity is from. Many gun advocate groups or organizations that I'm sure you've all heard of, like, for example, the NRA, or, for example, like the National Shooting Sports Foundation, you might think all of them would be categorically opposed to healthcare providers or social service providers talking with veterans about their access to firearms. But that's just not true. And I don't want to oversell this here. Certainly there are lots of folks who are gun rights advocates who think that healthcare providers or social service providers never have a place in asking people about their access to guns. And, I think that that's unfortunate. And, when we're, like we are in the business of saving lives, it's not something that we can always do. And as much as we always, of course, want to respect people's rights and their values. There are a lot of, maybe surprising number of gun rights and gun advocacy groups that support this kind of action in healthcare. The National Shooting Sports Foundation is certainly one of them. As many of you may know, they partnered a few years ago with the American Foundation for Suicide Prevention to raise awareness about firearm suicide and about gun safety as a way of preventing firearm suicide. There are particular organizations like the Maryland Licensed Firearm Dealers Association that are actively involved in suicide prevention. I saw that someone in the chat or the Q&A box talked about extreme gun violence restraining orders or extreme risk protection orders, which orders that are laws that I think in 5 or 6 states of family members of people who may be at imminent risk of violence to themselves or others, to get an order from a judge to temporarily, usually for about 30 days, take possession of someone's firearms. Those are relatively new laws, and we're still gathering data on them. But not that I think it was in March of this year that the NRA came out in support of those laws. So I think it may be that some of the conversation in our country around firearms and firearm suicide and having conversations about firearms when we're trying to save lives is shifting. I'm going to skip that. And in summary, many people, I think, are concerned that talking with veterans in a healthcare setting about access to firearms will be a sensitive or a potentially unpleasant topic. Certainly, sometimes it can be. I think that there's good evidence that many stakeholders across the political space here agree that saving lives is important, and that as providers we have a responsibility to do that, and that if we do it in a way that's respectful and that affirms the rights of veterans and service members and their families, there's a place to talk about human safety, especially amongst people who are at risk for suicide. Okay, now I'm going to shift gears a little bit about what we actually mean when we talk about safe storage. I've probably said the phrase 10 times already here. And so just want to shift gears a little bit to talk a little bit about what I mean. Safe storage, in brief, as a way of storing a medication or a firearm, since we're talking about those two methods, in a way that temporarily reduces someone's access to the medication or the firearm. I'm going to stop this video for now and come back to it. There are a lot of different safe storage options for firearms. I think one that most people think of immediately is storing the firearm outside the home. So, and this is one of the areas where the sensitivity around this conversation comes from. You're trying to take my gun away from me. You're trying to take my gun out of the house. That is certainly an option, and in terms of suicide risk, is the safest option. So it's the one that's associated with the greatest reduction risk. There are a lot of other options that are also associated with a significant reduction in suicide risk, which involves taking the gun out of the home. And the main idea behind these safe storage options is to really think about, again, how can I build in time and space to limit access to the gun or increase the amount of time between now and the time that the gun is functional or usable. So one relatively easy option is to use a firearm lock, so a cable lock or a trigger lock, and give the key to someone else. So many may know that the VA distributes free gun locks, cable locks. They look a little like wick locks to veterans. And you can use a cable lock on a handgun and then give the key to someone else, which renders the gun inoperable. There are options still for a gun safely. It's actually safer in terms of suicide risk just to store a gun unloaded and to store the ammunition separately. It doesn't make a lot of intuitive sense, but if someone has a loaded gun in their home and they decide to unload the gun and store the ammunition in a different room, they've actually just reduced their suicide risk because they're building in a little bit of time and space and a little bit of psychological space, being able to use the gun in a suicide attempt. A lot of creative solutions around how to disassemble guns. So you could just disassemble the whole gun. It takes time to reassemble it. You can move a firing pin. One of the creative solutions I heard was they put a firing pin in a bowl of water and froze it. And so in order to have the gun be operable again, the bowl of water would have to thaw, and of course that would take a couple of hours. Any solution that works here is really just thinking about how to store key components of the gun elsewhere, or to make them temporarily inaccessible. One man I worked with, he had a neighbor who lived 2 blocks away, and he'd known this neighbor for several decades and trusted him quite a bit. I think the neighbor was a fellow veteran. And when he would start to struggle, he would remove the firing pin from his gun. He would walk the firing pin to his neighbor's house 2 blocks away, and his neighbor would just agree to hold on to it. And when the veteran decided that he was feeling better, he would walk back over to the veteran's house, or his friend's house, and get the firing pin back, right? And that was an agreement that they had worked out. There's a lot of possibility for creative solutions here around storing firearms safely that doesn't involve just removing the gun from the house. The locking options for guns I just talked about, you can see the first 2 there are a cable lock, the orange cable lock. And the second one is a red thing is a trigger lock for a handgun. You can also buy lock boxes for handguns. They come in sort of different varieties. You can lock them with keys. They come with like combination safes. They come with sort of fingerprint unlocking. A lot of different ways to do it. For people, as many people do, they have long guns too that of course won't fit in a small box like a rifle. You can get a gun safe, and again, those can be locked and unlocked by combination or keys or fingerprints usually. And these things are for sale on Amazon. Like I said, VA distributes cable locks for free to veterans and their families. And if any of you are interested in getting cable locks for the veterans you serve, please contact me and we'll figure something out. We'll go back and talk briefly about temporary off-site storage for guns during at-risk periods. Like I just said, there are a lot of options for storing guns safely that keeps them in the home. And sometimes for a variety of reasons, people would prefer for a temporary period of time not to have guns in their home. It's sort of like we draw an analogy of, if someone had been an alcohol abuser for a long time and had been abstinent, was going through a rough time, that might not be the time for them to have alcohol in the house. They're going through a rough patch, it might just be the time to take the alcohol out of the house for a while. We sort of think it similarly with guns. There are different ways to store your guns outside your home. The most common one, and I think the one we all think of immediately, is to store the gun with a friend or a relative. In the majority of states in our country, that is legal, provided the person is not prohibited from owning a gun. In some states, however, it's not legal just to give a gun to your neighbor. And so I'd encourage all of you, and again, the VA is happy to help with you, connect you with these resources, to make sure you're familiar with the laws in your state of that option. There are a bunch of other options that don't involve friends or relatives. One is simply putting a gun in a storage facility. For most storage facilities, I think it has to be unloaded, but you could just simply send your unloaded gun to a storage facility and keep it locked in a storage facility for a month and then go back and get it when you're done. Police departments will also temporarily hold guns. I have to say this is, in my experience, not a super popular option among veterans. Some police departments, if you call them and say, I'm concerned about somebody in my home, would you be willing to hold on to my gun temporarily for a period of weeks or months? I know that some police departments will say yes, and you can just call and ask. Another good option for many people are gun stores or gun clubs. Often if people are members of gun clubs or shooting range, those places will store your guns sometimes for free or sometimes for low charge temporarily, and it's just worth it to call and ask them. A little bit now about safe storage of medication. So we just ran through safe storage options for guns, and talk a little bit now about safe storage for medication. There are different options for this too. I think one of the most common ones is simply to ensure that people in the home get rid of unneeded or expired medications. Every VA medical center has a medication disposal bin. The pharmacist at the VA Medical Center would know where that is, and anybody at any time can bring in their medications to those disposal bins and just drop them off. There are also medication disposal kits that are available. I think sometimes providers can give those to veterans or their families. I think you can also buy them online. And that's a way to get rid of unneeded or expired medications, and of course, I always encourage people to do that in healthcare. For people who are receiving an active medication and active prescription, there are ways to make sure that they do so safely and aren't at unneeded risk for suicide around receiving those medications. One is simply to ask the doctor or the pharmacist to provide the medication more frequently in smaller doses. So, for example, instead of getting a 3-day prescription of a medication, you might get the prescription every 7 days. Most doctors are willing to do that, and in many healthcare systems, including the VA, there are ways to work around co-pays, right? If you get a medication every week, you don't want to have 4 co-pays a month instead of just 1. And I know that especially for patients who are at high risk for suicide, the VA has a plan by which your co-pays for those medications don't go up. And I think many healthcare systems do the same. Of course, for people who are taking opioids, really all people who are taking opioids, regardless of whether they're at risk for suicide or overdose, you can, and it's important to have naloxone nasal spray, which is a opioid blocker, which essentially reduces overdoses. And for opioid and non-opioid medications, one way that we think is one that we think can be helpful. I don't know for sure that it reduces suicide attempts. I do know that it increases medication compliance and adherence to medication and to therapy, is to get blister packaging. For those who don't know what that is, that's when you buy cold medicine and it takes you like 10 minutes to get out of the package, or at least it takes me 10 minutes to get out of that little package. So blister packaging slows people down in their taking of medication. If you have a bunch of pills in a bottle and someone decides to overdose on them, it's pretty easy to pour half the bottle into your hand and take it at once. But if you have blister packaging, it can take a lot longer to get all of those pills into your hand. A lot of data that blister packaging reduces suicide attempts, but like I said, we do know that it increases people's medication adherence and their adherence in psychotherapy, and that is that that's likely to reduce their overall risk for suicide. So we will recommend that people consider blister packaging as a way to think about lethal food safety for medication. So in sum, as we're thinking about those different options for safe storage of both firearms and medication, I wanted to have a slide here to sort of re-emphasize what we can all do kind of in a day-to-day way as working with veterans and service members and their families who may be at risk for suicide. And I think one of the really basic things we can do is to just carry this knowledge forward with us and educate our colleagues about it. So educate them about the why lethal means safety is important for preventing suicide. Educate them about some of these ways that I just talked about how to store firearms and medication safely. Another thing we can, of course, do is when we're working with veterans or service members and their families is to talk about this directly with veterans, and especially for people who may be in distress, may be at risk for suicide, or may be in crisis, to really think about asking them about this. So if you're talking to a veteran who's in crisis, remember to ask, do you have access to a gun? And we're going to talk a little bit in those slides come right up about maybe some ways to do that, if how to, as you, like many people, might be feeling a little nervous about doing that. Just question, how would you recommend we approach questioning veterans in this instance, which is such a great question. It can be hard to do. Okay, so this is now a video that I'm not going to show. I think if Michelle is still with us, she can type the link to it in one of the boxes here. And then, yeah, Michelle, if you can also type the link to the video that I skipped before, sorry, the gun safety video. I'll just briefly mention these two videos here.
It's not, and I apologize the way it came out, but these are actually two separate links. So one is the link that you had referenced earlier, Dr. McCarty, and then the second link is the other is the second link is the save link. So I should do that in the chat log.
Awesome. And I'll just briefly say what each of these videos are. So the first video that I skipped is VA's gun safety video. It's a video that's intended audience is primarily veterans and their families, although it can be shown to anyone. And I've watched it probably hundreds of times, and I still like watching it. Really a video that speaks directly to the importance of storing guns safely when anyone in the house is having a difficult time or in distress or in crisis. And it specifically talks about statistics related to guns and suicide. I think it can be a great video to show to veterans to help start thinking about it. The second video that we're not going to show is a clip from a larger video called SAVE. SAVE is VA's gatekeeper training. Gatekeeper is a little like lethal means. It's not immediately obvious what it means. Gatekeeper training is a training essentially for everybody. So in this instance, it's a training about recognizing and responding to suicide risk, just for doctors or nurses or mental health professionals or even people who work in social services, but for literally everyone. So a video that's designed to help everyone learn how to recognize and respond to suicide risk veterans. And SAVE is an acronym that I won't go into, but stands for the steps that can take for when they identify a veteran at risk for what to do. That video is available at psycharmor.org. PsychArmor is a partner of VA and many different organizations. It's a nonprofit organization based in San Diego, run by Marjorie Morrison, that offers online trainings for people who serve veterans and service members. They offer a bunch of great trainings around military and veteran cultural competence. I have a good video called 15 Things Veterans Want You to Know, and it's just about, for people who serve veterans and service members, how they can do that better. And so we're really thrilled to have SAVE be one of the videos in their library. If you go to psycharmor.org, all you have to do is, I think it takes 30 seconds to create a log on a password, but it's free. And if you click on their courses website and you take in SAVE, it'll get you there. And it's about 25 minutes long. Thanks, Michelle. And so I think that's a great video to show to your colleagues or to anyone who's interested in learning more about veteran suicide prevention. Okay, sorry we couldn't show those videos here. It just didn't quite work out technologically. So in the last 20 minutes or so, I kind of wanted to get to this question that came up very early in our conversation, in our chat box conversation today, which is around, great, how do you talk to a veteran about, say, they've got full bottles of opioids in their bathroom, and you're concerned that they might be thinking about suicide and might use those opioids to attempt suicide. How do you talk to a veteran who sleeps with a loaded gun in his nightstand and who you're really worried about suicide? How do you talk to this issue and talk to them about their safety? First thing that I'll say is that there is no magic formula, unfortunately, and of course, as we all know, as people who serve other people, that all people are different, and there are a lot of different factors that can contribute to this conversation go well, or, in some cases, maybe not as well as we've hoped. So my first sort of thought is to really encourage all of you to rely on the solid foundation of skills that you've trained in and that you've honed through your experience in just talking with veterans and service members in a way that's collaborative and respectful and gives the agency to the veteran or the service member and their families, and really from start to finish has a conversation with, of course, their best interests in mind, but also in a way that really respects their values and their priorities and the way that they live their lives. So if I had one thing to say about how to have that conversation, I know it's a very general thing, but it's something that's really over time for me in thinking about this and having had conversations with veterans myself and having talked to a lot of different providers really holds true. We want to be a little bit more specific, or try to be here. And so we developed a few slides to help guide our thinking around how to have these conversations. And what I say straight up is that this is not science, that we don't have a lot of data to inform our guidelines. So these are really, some very initial ideas that have come out of talking with hundreds of veterans and providers about this. And I really welcome your input if you've had experience doing this too. So there are several factors that might impact the approach to this whole conversation, kind of going into it. And many of these, I think, are going to be obvious to all of you. One of them is, of course, your relationship with the person. If you have a really good and trusting and long relationship with them, you're going to be able to start the conversation differently than if you just met them 5 minutes ago, or if you're in a pretty rocky part of the relationship. How to approach the conversation might be influenced by how much you know about, say, the medications the veteran has and your knowledge about how lethal or non-lethal those medications are, or comfortable you feel talking about guns. Certainly know from a lot of clinicians who know a lot about guns that talking about them can be kind of uncomfortable. As a note, I might recommend, if you anticipate that you're going to these kind of conversations with veterans, you don't know very much about guns, it might be helpful to learn more. One of the easiest ways to do it, I found, is it does cost, depending on where you live, between $20 and $40, but you can go to a local shooting range and they'll give you a gun safety class and have you to shoot a weapon with live ammunition. And then that will just give you a sense of kind of what are the different parts of a gun, what does gun safety mean. In my case, when I started to learn about guns, how hard it is to actually hit a target. Sort of all of the things that we can learn about guns that might help us have these conversations more skillfully, more effectively. Another factor that might impact your approach could certainly be the urgency of the situation. So if someone comes in and says, I am really in crisis and I'm seriously considering, when I go home, shooting myself, of course, a very different conversation than someone who you're much less worried about. We talked about before some reasons for having the medications that they have might influence your approach. Someone's willingness to consider change, people and their willingness to change their approaches or change their routines impact your approach. If you're going to see the person again or when you're going to see them again might influence your approach. If you have a weekly psychotherapy appointment with them that they never miss, that's a good opportunity for follow-up. Maybe, seeing someone at a stand out in the community and not being clear that you're never going to talk with them again. So those are kind of, I think, moving parts to think about as you think about how you're going to approach this and what you're going to say. So I think in thinking about what you might say to someone, how you might broach this subject, another thing to keep in mind is that we want to emphasize that we're concerned about someone's safety and their health. And I think all of us on this call, that is part of our job descriptions, right? Our job is to help people be well in some capacity. In this case, if someone's, for example, in a suicidal crisis, might just approach it by saying, my goal is to keep you alive, protect you from hurting yourself. So that I'd like to have a conversation about keeping yourself safe. It's a way, again, to enter the conversation that doesn't mention medications, it doesn't mention guns, allow someone a chance to respond to this. And in my experience, if people had the same or different experiences, I'd love to hear about it in the chat box or in the Q&A. But in my experience, most people, even people in suicidal crises, are ambivalent about dying and are in some way at least receptive to hearing about this. And we hope, of course, that you're having these conversations not when people are in suicidal crises, but before the crisis or upstream of the crisis. My experience is people will say, well, Doc, that's your job to help me be well and to be concerned about my well-being. Tell me what you mean. So it can be a way to approach it. Okay. To think about it. When we get a lot is I ask directly, if I don't know if the veteran, say, has a gun in his or her home, should I ask directly, do you have access to a gun? I would say that depends a lot on what you know about this person, this veteran, him or her, and your relationship with them. But especially if you don't know someone so well, that kind of direct approach may not be the most effective. This is an example that comes directly from the folks at meansmatter.org in Boston. And this is text. And one way to approach this is just to say to someone, a lot of veterans have guns at home. And some of them in your situation do is store their guns away from home until they're feeling better, or lock them and ask someone they trust to hold on to the keys. Have guns at home, I'm wondering if you've thought about a strategy like that. So I think of this approach, or one advantage of it, is that it doesn't ask someone directly if they have guns. It doesn't assume they do. It just invites them to a conversation about this, and also allows them to say, oh, I don't have any guns at home, or no, I don't have anybody to give my gun to, or I would never do that. And with what they say, right, it kind of enters you into the conversation and gives you a point to go from there. The second quote here is for if a veteran says, oh, you can take my gun away from me, I'm not taking it out of the house. That's a way to say, that's cool, that's not an option. Are there other things that we could consider until you learn better? We're having these conversations, and those 2 slides of sample text are examples of this. And we probably just want to rely on kind of our basic oral or conversational skills around this. And I thought that the principles of motivational interviewing, for those of you who are familiar with motivational interviewing, I captured it nicely for this, is that when topics are sensitive, it can be really useful to engage in a conversation collaboratively and, in a sense, give control of the conversation, in this case, to the veteran or the service member or their family member. So we ask lots of questions about, is there something here you want to change? If not, what could happen that would make you want to change it? If there is something you want to change, badly do you want to change it? What are the pros and cons of changing it? If you might want to change it, what are some options for doing that? And our role as support or providers or whoever we are, to be collaborative and to really just serve as a resource to help the veteran or the service member get where he or she wants to go. And, of course, above all else, to emphasize that the veteran has autonomy here, that how someone stores their gun is really, or how they store their medication is really up to them. Hey. Cool questions.
Yeah,
even I've forgotten the answers to these questions.
So Megan, I was thinking maybe we could pass the first poll question, just looking at our time, and I was thinking maybe we could ask the second one, which I think we've talked a lot about in this session, but just really kind of getting everybody's input. That one question, building in time and space between impulse to act and the means to cause lethal self-injury saves lives. Is that true or false? And we may not have a full minute on this one. Let me just keep an eye on how people are responding. So we'll give this one about another 10 seconds. It's looking like people have been very attentive. good, Megan. And we're driving home that message. All right. I'm going to close it out. Okay. We'll publish this in 1 second once it's all processed.
All these questions in the Q&A box. These are such great questions. We had time to talk about them all.
I know, absolutely.
Yeah.
Okay. So everybody should see so obviously it looks like people have been very attentive, Megan, so that's exciting.
I'm sad.
I know, absolutely. So now we did have some questions, and Megan, I know you're looking at some questions, and then I was just trying to scroll through some questions you were presenting. One question that I saw earlier on was related to that follow-up care, and one of our participants asked about how your comment regarding the importance of follow-up care. So I just thought maybe if you could take a minute or two just to talk a little bit about what you see as the role of follow-up care and how important that is.
Sure. So in situations where it's possible, because I want to acknowledge that, there may be many encounters that you have with veterans or service members and their families for reasons of logistics or confidentiality or anything else, it may not be possible. For example, if you run into someone at a stand down and you end up in a conversation with them about this and they want you to follow up, obviously there's no opportunity to do it. But in cases where it is possible, I think it's really important to do, and I'd sort of summarize that like this, which is for someone who's at risk for suicide. We know that's a thing that kind of ebbs and flows, and as we talked about, passes quickly but can also come up suddenly. And for someone who's in an elevated period of risk, let's say you're doing a great job, but they come in with their wife, you have a conversation about taking their pills to the medication disposal bin after VA, and the wife volunteers to do it, and the veteran sort of reluctantly agrees, my wife can take the pills to the medication disposal bin. And you even, if you have time and you're thinking of it, develop an actual plan for doing that. Okay, so, how's that going to happen? When's it going to happen? Do we anticipate any obstacles to that happening? And it'd be important to follow up to make sure that it did happen. And if it didn't happen, to try to understand why and remove those barriers to happening. At the same time, there may be, in this medications example, additional medications coming into the home that you might want to follow up with. In one case that I remember, someone had done a really beautiful job around storing a firearm safely during someone's, sort of extended period of crisis. But then that person moved into a new home. Moved into a home where there was a firearm that was stored, locked, and unloaded. That wasn't that person. And so thinking about then, that's a whole human safety counseling conversation, possibly with a new person around following up around that change of environment. So checking in regularly with people and, following up on sort of specific plans that were made recently is crucial. One way that we do this in VA is to incorporate it as a part of safety planning. Imagining many of you on this call we have a rough idea of, what safety planning is. It's a way for people who are in really any kind of distress or crisis to try to help keep themselves safe. And one of the steps of the safety plan, step 6, is making the environment safe, and we mean safety. So in VA healthcare, for example, we document these human safety conversations and any follow-up on those, whether it's a week or a month or a year later. in that safety plan document.
Great, Megan. And maybe one more quick question, because I want you to be able to present your other content, and then give us a few minutes for some questions. There were some questions about free CEs or free CEUs, and I thought you may want to just touch on some of the resources that you're familiar with. I know the VA has an awful lot of resources, so just wanted to give a question an opportunity to be answered.
Sure. A very nice segue. It's a nice softball for me, Michelle. Thank you. Into my last slides. So to answer the question about free CEs, I think there are a number of organizations online that can help you get those. The one that I would recommend, especially for topics around military and veteran cultural competence or healthcare or anything else, is that organization I mentioned before, PsychArmor. They have lots of free CEs, and you can look there. I was about to mention something, but as I'm doing it, my brain is telling me that I'm not sure they give CEs for this. It is a longer military cultural competence training that's a joint effort between VA and DoD at, I think it's train.org. Let me just Google it here. Internet seems to not be working very well. That's funny. I think it's train.org, or if you Google train and military veterans cultural competence, you'd find it. I think that organization also offers CEs. Yeah, it's train.org, the Train Learning Network, powered by the Public Health Foundation. It's there too. Okay. I'm going to spend a couple of minutes talking about resources, and I want to re-emphasize that I am certainly available after this webinar to answer questions about resources or really anything else. I'm so glad that so many of you are here and so engaged and thinking about these questions with me. The first one I've listed here is maybe the most important, because this is a suicide risk management consultation program that is available to every single one of you on this call. It is a consultation resource from the Rocky Mountain MIREC, and a MIREC is essentially one of our many VA acronyms for a research and education center in VA, and this one is located in Denver, Colorado. It's staffed by suicide prevention experts, psychologists, and psychiatrists, and you can call them at the number there or go to the website there. Schedule a free consultation with one of their experts regarding any veteran or veterans that you in any way have contact with or care for. So about a year ago, this resource had only been available to VA providers, but we opened it up to non-VA providers. So any person who cares for veterans in any context in the country and is concerned about that veteran's suicide risk can call this number or use the website to schedule a free consultation about that. They do any kind of suicide risk, so around assessment, around medications, around conceptualizing risk, around trying to track down resources for the person to help combat their suicide risk. They also are experts in what we've just talked about around lethal means safety counseling, so around thinking about risk around firearms or occasions or other lethal means, and also how to talk to veterans and their family members about this. So we want to remember any resource from this call, this is the one to remember. And you can, again, call them and schedule the consult free. And here are some other resources. One of them is a resource I've talked about multiple times today, the Means Matter organization in Boston. They have a lot of data on their website about why access to lethal means is important. the one mentioned on the previous slide, the Rocky Mountain MIREC, they also have a web page that talks a lot about research evidence and lethal means safety counseling. So if you didn't want to call and get a consultation, but you just wanted the information, they have that second website listed here. We just talked about the VA Psych Arm or SAVE training. That was the gatekeeper or layperson training that I talked about. There's the website for that. If you'd like to do a lethal means safety counseling training formally, you can go to the Suicide Prevention Resource Center website, so sprc.org, to take the counseling on access to lethal means training. It's about 2 hours long, although I think it's being revised right now. I'm not sure if the revised training is up. It's a great training, and anyone can take it for free. And, of course, if you're immediately concerned about a veteran or a service member or a family member of them, that you're immediately concerned that they might be on the brink of a suicidal crisis, of course, always call the Veterans Crisis Line and press 1 for veterans or loved ones of veterans. Go to veteranscrisisline.net. They have a text and a chat service. And then always, of course, in urgent situations, call your local VA suicide prevention coordinator. I think not everybody knows this, but suicide prevention coordinators exist all to help veterans in the community who are getting care in the community and the people who care for them. So suicide prevention coordinators don't just serve veterans who are in VA. If you called your local suicide prevention coordinator and said, I work with a veteran and I'm helping him get the care he needs in the community, he doesn't come to VA, he doesn't want to, I'm helping him get the care he needs, the suicide prevention coordinator will absolutely help you with that. We listed a couple of VA resources here. I'll go through these quickly. The first one is called Make the Connection. This is an absolutely incredible resource online that has hundreds of short videos of veterans, actual veterans, not actors, saying about their journeys to recovery or through recovery if they're not there yet in different kinds of ways. So a lot of them are about mental health, but they're certainly not all about mental health journeys. And it's an incredible resource because you can sort by the gender of the veteran, the service area of the veteran, the thing that they're struggling with. And so especially for veterans and their family members, I think this is an incredible tool for reducing stigma and thinking about the path to recovery and all the different ways one can get there. Coaching care, I mentioned before. Look, here's the website that I couldn't think of before. Coaching into Care is the resource for family members or friends of veterans who are trying to get the veterans they care about into some kind of support or health care, but aren't quite sure how to approach the conversation, or maybe they've tried, it hasn't gone so well, and so they're looking for some support around how to have that conversation about getting into care. That's what this resource is for. And finally, and what may also be really useful for a lot of you, Office of Mental Health and Suicide Prevention has put together this community provider toolkit. It's for people who don't work in VA but serve veterans and service members. And it's got a lot of different resources in this toolkit at this website around trainings on veteran issues, including military culture, and just a lot of different resources for providers who serve veterans. So if anybody's interested in that, I'd encourage you to take a look there. Pop up, and I think this is my very last slide, and I think all of the bullets on the slide will, at this point, very familiar to all of you. Of course, suicide prevention is a public health priority, and lethal means safety is an important part of that priority. Because people who have easy access to lethal means, like firearms or like medications, are at elevated risk for suicide. So from lots of research and lots of data that lethal means safety interventions or promoting lethal means safety is strong evidence-based practice for preventing suicide. In particular, for veterans, we know that firearms are an important focus for lethal means safety because about 2/3 of veteran suicides are firearm-related. as we spent also a fair amount of time talking about today, medications are an important method for suicide and suicide attempts, especially among women and veterans. I'm going to say about the conversation, about how to have these conversations. There is no one-size-fits-all. Don't have good science or scientific evidence about how to do it. I just encourage all of you to rely on, your good social and clinical skills and practice it with people, and to not be afraid to initiate these conversations. I think these are coming from a place of wanting to help people be well and keep them safe, and a place of respect. Hard for these conversations to go really wrong. So I'd encourage you all to and to encourage your colleagues to raise this issue, and that there are resources and training materials in the slides I just went through that can help you. And I'm not sure how much help I would be as available as a resource for that. I am always available over email to answer questions and to connect folks, whatever resources they need. We know that suicide prevention for veterans starts in communities. It certainly doesn't start in offices in Washington, D.C. And so we really see one of our main and most important roles is to try to help support all of you in doing the work in your communities to prevent suicide. I think that I'll wrap up, and we've got a few minutes for questions.
Great. So much, Dr. McCarthy. We appreciate it. There has been an awful lot of chatter in our chat panel and in our Q&A. So if before we have a few more minutes for questions. If there's anything that you would like to post, please do that. There is a question that I wanted to raise that was from kind of midway through the presentation, and that it relates to the disruption of the process of that impulse, and thinking about how people can incorporate that short-term strategy into a longer-term mindset. And I don't know if there's been much research done on this, Dr. McCarthy, but really just thinking about as we're recognizing the difference that 30 to 60-minute window can be, or the delay on enacting on the impulse. How does that also correlate to helping someone begin to turn this into a longer-term strategy?
Sure. Yeah, this is a great question. I'll say up front, I think has a complicated answer for a bunch of different reasons, including limitations of what we know around science, and including, some of what can be political sensitivities in particular around storing guns safely. The first thing that I'll say is that from a research perspective, it's a good idea to store your gun unloaded and locked all the time. Which I mean, there's a lot of research data that says people who store their guns loaded are more likely to be harmed by that gun than they are by, say, an intruder or something like that. So there's good research evidence, at least, to just as a kind of a matter of course, a default, to always store your gun unloaded and locked. I'm well aware that there are a lot of people, veterans and non-veterans, who don't feel comfortable doing that always, right? For various reasons. They might live in an unsafe neighborhood and want to keep their gun loaded in order to protect their homes. And I think as people who are veterans, we could then have a conversation about, are there other ways to keep your house safe? If you get a big dog, could you install, automatic lights? I mean, I think there are different ways to have that conversation. But, sort of starting from the point, are willing to, I think about guns, always storing a gun safely, which is unloaded and hopefully locked, a great idea. They're willing to do that. It's safe for everyone in the home. And people who aren't, then I think it becomes a conversation about wanting to identify periods of elevated risk and kind of weighing the pros and cons with them of their suicide risk, the other factors that might be causing them to not store their guns safely. That was a little vague. I hope it was clear. But I think that insofar as we can always encourage people to store means safely, that's great. But really want to be sure we're focusing on it for veterans who are at risk or are in periods of elevated risk.
Thanks so much, Dr. McCarthy. The other question that we had was about the data that talks about, is there data that talks about whether people who attempt or complete suicide, if they've seen a provider in the last 6 to 12 months?
Sorry, could you say that again? I want to make sure I understood.
The question related to is there data or research that talks about people who've either attempted or completed suicide seeing a provider before they attempt?
Seeing a provider. There are various kinds of data about this, both for veterans in VA care and in general in the population, the general population. And I'm not going to know the exact numbers on them, but what I do know is that they're very similar. So I'm going to talk about data from VA's Behavioral Health Autopsy Report and tell you from reading of the research literature, this is sort of similar numbers to what happens in the general population, which is that a significant minority of people who die by suicide, so somewhere between 25% and 40%, depending on what study you look at, seen a healthcare provider within 30 days of their death by suicide. So that's a really significant number if you think about how often we all go to a healthcare provider. Probably for many of us who are at least feeling healthy, it's probably not once a month. And so a significant minority of folks see some healthcare provider, often in primary care, within a month of their death.
That's helpful. Thank you so much. Okay, so we are actually right almost at the top of the session. It's 3:58. So I think we can wrap up here, and Dr. McCarthy was really nice to offer her email address. So I know you have her contact information if there's something we weren't able to get to on the session. There was several comments about the value that people saw in this presentation. So we appreciate that feedback. We will be sending a link. I'm going to follow up. You'll get an email from me, Michelle Cleary, that will include a link to an evaluation, some information that was in the chat as well. There was an awful lot of really great resources that people shared. So we'll try to extract that information and get that out to you. We'll also include the slides. And then I'll make sure also the links that we posted, including the links to the videos, will be included in that follow-up email as well. This is one of the times we've had a single center on a topic that is such an important piece of the work that we're all focused on today. So we very much would appreciate your feedback on this because we are excited about this opportunity to have someone like Dr. McCarthy help us move forward in our work. So we encourage you to complete the evaluation and let us know if you have any other questions. With that, I think we can wrap up. Thank you all very much for participating today. And thank you also to Dr. McCarthy for taking the time to do this and support our work.
Much, Michelle. I just want to thank everybody for taking the time out of what I know are their very busy days. 2 hours is a lot of time to attend. And just please contact me at any point with any questions.
Thanks so much. Have a nice afternoon, everyone.